So for today, we're gonna hit on a couple different topics. So the first part's divided up. We're gonna talk about pulmonary embolism a little bit. If you remember last week, we talked about. What? Are we gonna test back in? Oh, yeah. Sure.
I mean, I'll keep with the study from.
Sorry. Just passing the middle on around. Thank you. So that's why. Yep. Yeah.
All right.
Oh, okay. Yeah, sorry. So we talked last week about different kinds of shock. What type of shock is associated with PE? Say that again. What type of shock is associated with PE? Obstructive, right? Same mechanism as cardiogenic because the pump is failing, but this is a non-cardiac source, right? So this is causing a perfusion issue. It's causing the heart not to pump as well, but it's from an external source. All right, so a PE can actually be solid, liquid, or gas. The most common cause is a clot. A DVT is the most common type of clot, but the pulmonary embolism is a thromboembolism, okay? They can be caused by anything. They can be caused by a tumor, bone marrow, amniotic fluid, whatever. Okay, but what you need to know is it is something that is in our circulation that's going to block the pulmonary vasculature. Okay, so DVTs, super common. I think you guys have talked about those already in your previous class. If you have not, please feel free to go back and look. When we talk about PE, this is a medical emergency, right? Airway, breathing, circulation. This affects your lungs and the circulation of the lungs.
Sorry, on the first slide where it says the right side heart under the thromboembolism, does that mean it's more common in the right side?
More common in the right side. Yep, those more common in the right side. Okay, good. Okay, so best way to prevent a PE is to have a good strategy to begin with, right? I'm gonna watch a quick video on how PEs are formed, just to kind of give us a frame of reference on what we're looking at. We have a couple people who couldn't make it today, so I want to make sure I include them.
And may obstruct the blood flow very considerably. In DVT, there's the potential danger of a blood clot breaking free and travelling with the bloodstream. It can be transported over long distances along the large veins of the body. As a consequence, the clot is able to reach the heart. From here, it can be transported into the arteries of the lungs. The clot has travelled through rather large blood vessels for most of its journey, but the vessels in the lungs are much smaller in size, as they branch and divide to cover the large surface area of each lung needed to capture life-giving oxygen. The clot may become stuck in these smaller vessels. A blood vessel in the lung with a blood clot lodged in it is known as a pulmonary embolism, or PE. Although PEs may occur less frequently than a DVT, they can be fatal if not identified and treated promptly. The most common sign of a PE is shortness of breath. However, symptoms may include some or all of the following: pain in the chest, especially when taking a deep breath or with a cough, coughing up blood, fast heart rate, fast breathing. If you have or have had a DVT and think you're having a PE.
So DVTs are very common. PEs are less common, but a DVT can lead to a PE, and that video explains why. Because the vasculature in the leg, right, is bigger, and so as it breaks off, it goes to the right side of the heart, right? And from the right side of the heart, it pumps directly into the lung, and that's where it gets lodged, okay? So that's where the DVT and the lung, and the right side of the heart all kind of go together. Okay, does that make sense? So when we're looking at this, we know that when you have an obstruction, just like when you had an infarction in the heart, right? A clog or obstruction in a coronary artery would cause ischemia downstream, right? The heart muscle would die. Same thing with the lung. As it gets in there, it's going to cause the lung tissue to not be perfused, and it's going to cause it what we call dead space, right? It's an area of the lung that is not able to exchange oxygen and carbon dioxide. So when that happens with that, we kink the hose, we have pressure back into the right ventricle because it's trying to pump against that clot. And it can cause low blood pressure, it can cause cardiac output to go down. And then above all, we know that we're gonna have some respiratory symptoms as well, okay? What we know causes this, so prevention is the best strategy. What we know causes DVTs, which then can lead to PE, right? Immobility, people who take cross-country road trips, people with some type of a condition with an increased tendency to clot, so thrombophilia, venous stasis, which we're going to talk about a little bit later. Anybody who has surgery, right? Because it can be a fat embolus, it can be an air embolus, it can be amniotic fluid embolus. So anything that would risk disruption in circulation, right? Chronic AFib. We know that AFib leads to blood clots, right? Blood clots can go to your brain, they can also go to your lung. Anything with tobacco, any type of nicotine causes vasospasms, right? Which then increases our chance of clamping down and leaving blood stuck in one area, which then can clot. This word is called Virchow's triad, and this is what we know are like the top three things that when they come together, make our clot, our venous stasis, some type of damage to the lining of the vessel, and hypercoagulability. Okay, so when we talked about our coronary heart disease, right, same type of things. The blood is pumping through a lining. If that lining gets disrupted, then more platelets and more thrombin type to stick to it, which then can make a clot. And then if for some reason there's some type of reason our blood is clotting faster, then we have a problem. So depending on where it is, will let us know how much damage it is, right? Some PEs are small and we find them incidentally, you treat them, they're fine. Some PEs are massive and they're very lethal. So if it is large enough, it can cause sudden death, right? So if you have a massive clot that you throw, again, we didn't do the TEE, we didn't find the blood clot, we cardioverted, that clot went out, instead of going to the brain, it went to the lung. You lose that one side of the lung, and instantly we've got some issues, right? That can cause a sudden death. We can have permanent lung damage, just like a myocardial infarction, you can have a lung infarction. The smaller ones might not cause a permanent injury, but if they're not caught, they can also lead to whatever was causing it, can make more clots. Or if you already have compromised circulation and you already have compromised, maybe you have COPD or something where you're not oxygenating well, it can make it worse. And then some people have small recurrent emboli that they know they need to get treated, right? It can also be from fat. So we see this a lot after you have a long bone fracture. So your humerus, your femur, if they have a hip repair, anything to do with that, pieces of bone marrow can actually break off or fat and they can go into circulation and cause an embolus that way. Okay, so the most common emboli that doesn't involve a clotting problem is the fat emboli. Okay, what we're gonna see are these things right here. Okay, you're gonna see these more in the large, but you're gonna see the people that have a sudden onset, shortness of breath, difficulty breathing, we talked about the heart when we were talking about chest pain, right? Asking them to rate it on a scale of 1 to 10. And then do you remember me saying, is it worse with a deep breath? Is it worse if I push on it, it's reproducible? Pain that's worse with a deep breath, we know is indicative of something to do with the pleural space. Okay, so if they say it hurts with a deep breath, also, if you're gonna mix that with feeling very anxious, right? They're gonna be tachycardic and they're gonna be anxious a lot of times because they're short of breath. These all kind of go together. If you have a patient that presents this way, especially if their oxygen level is on its way down trending, think PE. Okay? They also sometimes get a low grade fever. Or you might end up with widespread cyanosis, or they may lose consciousness and have PE. Okay. Down here at the bottom, it says, all of these symptoms sound very familiar. They sound a lot like PE, they sound a lot like pneumonia, and some of them sound a lot like a myocardial infarction. Okay, so your job is to assess and to anticipate what we're going to do, recognizing that all three of those things are a pretty good emergency, right? So how am I going to differentiate heart rate and trouble breathing and chest pain? What would I check if it's an MI? What are my go-to thoughts on that? EKG, cardiac enzymes, troponin, right? All of that. Okay. What am I going to do if I suspect pneumonia? Same thing, shortness of breath, low sat, chest discomfort. What am I going to do for pneumonia? Blood cultures, chest x-ray, CBC, I'm going to check a white count because it's an infection process, right? But our assessment is going to let us know, like, this is not good. And then we kind of start down those paths of which intervention are we going to take? That is what the difference is between being a first level student and understanding the body processes and what is pneumonia, right? And what is this or that? And being a nurse who's going to graduate in May, where you walk in and your patient is short of breath and clutching your chest and say it hurts and I can't breathe, right? You know, it's not just one thing. You know, it could be three. And so what are you going to use to get you down the right path of implementation to treat that patient? See what I'm getting at here? Okay. Kind of the gold standard is a CTA. That's a CAT, whatever CAT stands for, computerized tomography angiogram. That's the one where we're in the hospital. They're going to say, I need a 20 or greater in my AC because they're going to use high volume contrast. Because what they're going to do is they're going to pressurize a large volume of contrast and it's going to light up the lungs. Okay, I'm not looking at soft tissue. I'm looking at the vasculature and it's going to tell me. Okay, so if you're again, just like when we talked about the cath lab, what do we need to make sure a patient doesn't have before we inject them with a bunch of stuff? Allergies to shellfish. What labs are we going to check?
Kidneys.
Your kidney function, right? Okay, if you have your diabetics, what do we do with diabetics who get injected with contrast? What do we have to tell them? Not to take their metformin, right? Because their kidneys are going to be taxed. This is where we're putting it all together, right? If for some reason they cannot do the contrast, we can do what's called a VQ scan, which is a ventilation perfusion scan where they inhale the radioactive isotope and they do a scan. The chest x-ray sometimes can show evidence of the PE, it won't actually show it, but it can show some different changes that we know with it. And then there's pulmonary angiography. This is like the cath lab for your lungs, right? Instead of going to the heart, we're going to go into the pulmonary vasculature. Okay, so our lab testing. D-dimer, who's heard of D-dimers before? Okay, we look at that. Now, if a D-dimer is negative, can you have a false negative and there's no clot? If a pregnancy test is negative, it's usually negative, right? If a D-dimer is negative, usually no clot. Now, if it's elevated, there could be a clot or it could be something else. So we can't solely go on a D-dimer, but if a D-dimer is positive, we definitely have to rule out a PE, okay? If they're really struggling with breathing and perfusion and oxygenation, we're going to do an ABG and take a look at that. We're also gonna look at our co-ed labs. We've talked about that, right? Our PTINR and our APTT. We've talked about them before. We talked about going into for our clot in the coronary artery. We're gonna talk about this too. Okay, so there's two different pathways we're gonna talk about. We have, oh, that's supposed to be clotting, not slotting. Sorry, I can't spell. There's extrinsic and intrinsic. Okay. I have a handout for you. And it's a handout because I borrowed it from another resource. So I can't exactly put it on there for you guys to print out. Okay, but I really like it and it's a good cheat sheet. So keep this. This is a picture of clotting cascade. How 1 to 5, how familiar are you with how blood clots and the clotting cascade? 3, 4. I have no idea what you're talking about. That's with you too. All right. So when we're understanding, right? What do I need to medicate with? Am I going to use heparin? Am I going to use Coumadin? Am I going to use Xarelto? These Lovenoids, okay? This chart is really gonna help you, okay? If you're like me, I don't really pay attention to when I use heparin or why I use heparin instead of Lovenoids, but you looking at this, it makes perfect sense. So if you look at the top, you have an intrinsic and you have an extrinsic pathway, okay? So one has to do with vessel damage and one has to do with tissue damage. And if you can follow it down, both of them lead to this common pathway in the middle. You follow me so far? Okay. Right underneath that common pathway is where you're going to find the things we're testing for. Your prothrombin, your thrombin, okay? That tells you where we're at in the clotting process. So based on which lab I draw, it's going to look at different time markers in this pathway of how a blood clots. Okay, so it's really good to know APTT and PTINR. We know those are coags, but if you want to know why we draw one for Coumadin, why we draw one for heparin, right? Here's why, because it activates in a different point in this cascade. So when we say that we want your PTINR to be elevated, we know that we want that to be elevated before we even get to that fibrin, that fibrinogen that strengthens that platelet plug. Okay, when we look at our APTT, right, we know that we're going to look at a different point in that pathway before we get to down here between 4 and 3, before we get to that fibrinogen completely. So on the bottom, you're going to see numbers 1, 2, 3, 4, 5, 6. Those correlate to different medicines and where the medicines work in this process. So if you look at number 3, which is heparin, it's going to work from the factor X to factor XA. So it's going to keep thrombin from even being formed, right? It's going to slow that part down. If you look at your Coumadin, which is a 2, that's going to go clear up here and work on vitamin K, right? And it's going to work in the liver. So just when we're talking about these different medications, understanding where they work gives you an idea of why we're testing for them. Does that make sense? Yes, no, maybe. Is this something you guys know pretty well? Okay, sometimes you talk about it in farm, sometimes you talk about A&P, for some of you that might be a little bit. So just look at the bottom, and this is what I want you to know. This stuff's in your book, this stuff is in the PowerPoint, but keep this handy, because looking at the bottom here, it's going to tell you what each med does. So if I ask you, what's the difference between Coumadin and aspirin, right? Or what's the difference between apixaban and enoxaparin? Being able to at least understand why, right? Why it works, how it works. Danielle shaking her head. That's a lot to remember. It's a lot to remember. I'm not asking you to memorize it, but I just want you to understand it, because I don't want you to think that all blood thinners are exactly the same and that these are the labs we just draw just because. Okay, again, I want you to kind of understand why. So knowing this, keeping this in our back pocket, we know that we have to get them anticoagulated, right? We know that a lot of our patients, once they have a high risk of PE or they've had one in the past, they're gonna be on anticoagulant all the time. And then we also know that clients that have a PVT are prone to getting PE. So you have to hit all the different medications to do all these different things. So our normal range is right here at the top. Okay, here is our normal INR. We said 1 was about normal. We said our APTT, our normal was under 35. Okay, so that's about right. We use our intrinsic pathway, which if we look on here, right, that's usually caused by vessel damage. Okay, we're gonna do the APTT, and that's heparin. So when we're using heparin on our patient, or titrating the heparin, we're looking at one pathway. And we're looking at this lab. When we're looking at the extrinsic pathway, which is not coming from inside the vessel itself, we're looking at tissue damage, right? Then we're looking at the PT-INR, which then we look at Coumadin. So this is what that big paper that I gave you, this is what it boils down to is, if it's happening inside the vessel itself, we're gonna use heparin and we're gonna check our APTT. If it's coming from an outside source, we're gonna check our PT-INR and we're gonna medicate it with Coumadin. Okay, so just understand, yes.
So for them to figure out like what to put them on with a PE, they check to see if there's vessel damage or tissue damage, and that's kind of where they go with it.
Great. So when they're on heparin though, this is the lab that we're gonna look at over and over and over. Okay, if they're on Coumadin or warfarin, then we're gonna look at this one, so depending on where it's coming from. Okay, so just understand which lab you draw for which medication and where it originates. Fair enough? Okay. This is a whole lot of information that just tells you how a clot is made. So look at this right here, okay? So we have factor 10A, which is right underneath common pathway. Eventually, that prothrombin turns into thrombin. That thrombin turns into fibrinogen, which turns into fibrin. And basically all that fibrin does is that it takes all the platelets and that's what holds them together to make the clot. Okay, so thrombin turns into fibrin eventually, and that is what holds your clot, your things together. So one of the medications that we used when we were looking at coronary artery disease was a fibrinolytic, right? Fibrin holds those platelets together. So we talk about a clot buster, right? A fibrinolytic eats away at the fibrin so the platelets can go free and we don't have a clot anymore. That makes sense. Some of you are looking at me like I'm crazy, but that's okay. I'm all right with being crazy. Okay, medications that you need to know. Okay, you're gonna see these for this exam, but also you're gonna see them going forward also. So if you had to focus on any, these are the ones I would focus on. Our antiplatelets, we already went over those are not new, right? Those are the ones that are that keep the platelets from sticking together. We know that one. Warfarin, this should be something that you've known for a long time. If it's not, please go back and look it up. We know that warfarin works on against vitamin K, and if we look here, we see that it is made in the liver. Okay, so warfarin, we do that. And what lab do you draw for warfarin? The INR, that one you already know. Heparin and Lovenox, have we used these in the past? Yeah, those should not look new, okay? And the reason why we use them is that we want that fibrin to not be activated, because what does the fibrin do? It holds the platelets together, right? So that's why we give heparin, that should not be new. Okay? Eliquis and Xarelto, these might be new. Okay, those are the ones that you might want to look at. These are the ones that we're putting our patients on instead of giving them the warfarin where they've got to get their blood drawn and they've got to have this algorithm of 7 milligrams on Tuesday and 2 milligrams on every other Saturday. We send them home on these. Okay, those are ones you're going to very commonly see. What I want you to remember about these: heparin does awesome, can cause something called heparin-induced thrombocytopenia. We'll talk about in the next slide. These don't do that. Okay? So we like these because they don't have the bleeding risk that heparin does. Okay? This one down here, you can know what it is. That one I wouldn't spend too much time on. And fibrinolytics, know what they are, but we're gonna hit on those again when we get to our stroke patients. So you already know your antiplatelets, you already know what warfarin is, you already know what heparin and Lovenox are, okay? But now we just need to understand the difference of one to the other. Okay? The heparin-induced thrombocytopenia, remember, your apixaban and your rivaroxaban, right? Your Eliquis and your Xarelto, less monitoring because they don't cause heparin-induced thrombocytopenia. So if you had a test question that said, what medications cause heparin-induced thrombocytopenia, what would be your answer? Heparin, enoxaparin, or your Lovenox. Okay, these don't cause that. These don't cause that, right? It's right in the title. But what that does is it causes your blood to clot even when you have heparin in your body. Okay, so what happens with that is you have blood clotting in different places. Okay, and you have an increased risk of clot even with the clot or the blood thinner. So that's something we need to know. If for some reason they develop it, you have to stop it immediately. It's listed as an allergy. We don't use it. We have to switch to something else. So not very many people have it. Okay, but if you see this develop where your patient is starting to have more clotting, we definitely want to address it because we don't want to have a bigger issue. Okay, so this looks like a lot, but when you break it down, it shouldn't be anything that is too insurmountable because a lot of it should be at least a little bit familiar. Okay, we give a lot of Lovenox. How many have given Lovenox in the hospital setting? Right, that's the one where you give it, you don't pop the air bubble out, right? You give it in the belly. Some of our hospitals are still using the heparin too, right? They do it every 8 hours. Why would we use Lovenox? Why would we use heparin? Why, looking at this chart, if one is 3 shots a day and one is 1 shot a day, why would you not just do the 1 shot a day? Cost is a big one. Yeah, Lovenox is super, super expensive. But also, how long do you think Lovenox lasts? 24 hours, probably once a day. How long does heparin last? 8 hours, right? So depending on what your person is getting it for, they're both in the same kind of category, but again, indications. Okay, so, and cost is a huge one. The only thing I want you to look off of this slide is to look down here, and that is the reversal agents. Okay, so if you have somebody who's taking apixaban or rivaroxaban, right? We use this thing called Adanexa, which is andaxonate alpha. That's our reversal agent. Okay, so that's what you need to look at. There's also something that is called 4-factor PCC. That is something that we are starting to use more and more. For a long time, it was if you were on a warfarin, we always gave vitamin K. We can also use this 4-factor as well. Okay, and then we know that heparin's reversal agent is protamine sulfate. Hopefully you remember that. If not, we can look that back up. And for all of these categories down at the bottom, same thing, the Adanexa alpha and the 4-factor PCC. So I'm not asking you to memorize everything, but if I said your patient is taking apixaban and is needing to have emergency surgery, what medication would I administer? Right? What are our options? We have 2 of them right here. Okay. When we started introducing these long-acting, our Xareltos and our medications like that, the big concern was that we couldn't reverse them. So Coumadin, all you had to do was give them vitamin K reversed. And so for a long time, it was really difficult. It's still not very cost effective to reverse them. but we have to do that risk benefit, right? If you have a healthy 45-year-old that has chronic AFib, those are great medications to use. They're probably not gonna fall and hit their head nearly as frequently as somebody who's older, right? So it's good to have these in our back pocket, just know they're very expensive. Okay, here's some specific data, if you wanna know how these work. Normally, we give heparin for about 5 days until what lab are we looking at for heparin? APTT, right? Until our APTT looks good, and then we switch into the oral. Okay, so we can do them the same time, right? So we can start our heparin and we can start our oral, and when everything looks good and we get them the right level, then we back off the heparin and we keep them on the oral until they're where they need to be. If they have limited risk factors, right? The only reason you're at risk for a PE or a DVT is because you had, you broke your leg and you're in a boot, right? Non-weight bearing for a month. That's limited. Okay, so we're gonna do it for temporary, 2-3 months. If it's something that's chronic, you've got AFib, right? You've got venous stasis, you've got, some type of perfusion issue, then we're gonna be in something a little more long-term, right? If you've had a PE in the past, and they think that maybe you would have one in the future, we're probably gonna keep you on it for forever. Okay? Then those thrombolytics are what we're gonna use to break apart wherever we're at in this clotting cascade, right? That's holding all those platelets together. And we wanna get the blood flow back going. We wanna make sure that we have reduced the pressure in the right side of the heart where that clot is. And we do need to make sure we remember that anytime we are breaking apart clots, we do have risk of bleeding in the body. So it's not just located to the one area. Okay. There's something called a vena cava filter that you can put in. So if you're somebody who is at risk for clots or you have a history of them, they can put this little filter in and it'll catch them. Keep them from going back to the lungs. This is a video on how they can go in and actually pull out the clot, and here's some clots that they pulled out, and you can actually see where the lungs would look, right? So when we talk about a clot, sometimes we think of like a little blood clot, but it can actually clot in the whole vasculature, right? This person clearly will be on anticoagulants their whole life if they were able to get to this point. Okay, nursing care. Making sure we're evaluating our patients. Who is at risk for developing clots? We talked about AFib. Who else is at risk? Older people with immobility.
Autoimmune.
Autoimmune. Smokers.
Drivers.
People with sedentary lifestyles.
Oral contraceptives.
Oral contraceptives, right? So if you have any of these or you have more than one, we need to start looking at risk factors, right? If you smoke and you're on birth control, boom, you've got 2. If you have a super sedentary lifestyle and you're a smoker, there's 2 right out of the gate. So making sure we're doing some screening and then making sure that we are doing our assessment, okay? Making sure we're doing frequent respiratory, making sure we're taking blood pressure on both sides. Why would you want to take the blood pressure on both sides? Right, depending on where the backup to the blood is, we could have a higher pressure on the right side than the left. Distended neck veins, again, if everything's backing up, here's one that's new. Petechiae on the thorax. What's petechiae? Those little blood things, little blood specks not blanchable. If you see that on somebody who is short of breath and having chest discomfort, instantly think that we've got a bad MLM. Okay, so if you have a little old lady who comes back from surgery, she had her hip replaced, and all of a sudden she's having all these symptoms and you do your full assessment, because you're a good nurse, and you notice petechiae in her chest, instantly think like, oops, we really need to get busy on this, okay? Our first indication that somebody is hypoxic is what? Consciousness, level of consciousness, okay? So if they start to have changes in their level of consciousness, they start to be confused. We want to make sure we're paying attention. Look at that AEG. We want to position them so that they're breathing as well as they can. We're gonna make sure we monitor for all the things that we monitored so far. The heart monitor, we might do our central line, we might do our pulmonary wedge pressure. We're gonna do for chest pain. And then if we do anything that is interrupting that clotting, we have to look at what else we're doing, right? Anywhere that we give you medicine, you could bleed. Anywhere we've done an IV stick, anywhere we've given you a shot, the Lovenox in the belly, nosebleeds, in the catheter, all these type of things. We have to make sure that we're watching for bleeding. And again, level of consciousness, right? We have lots of bleeding in the brain, areas that could bleed. And then if they're on heparin, we need to look for that heparin-induced thrombocytopenia. Okay. All of our educations, these are very similar to what we've talked about in the past. We need to make sure they're taking their medications. We need to make sure they understand what maybe caused this in the first place. What do I need to adjust? We need to make sure that we're doing the things that we talked about when we did heart, about making sure that you're moving, making sure your circulation is good. One thing that we need to talk about is if we do have you on an anticoagulant, your diet changes, right? For our heart patients with atherosclerosis, what type of diet do you want them to follow? Low fat, low salt, right? Make sure you watch your sodium intake, daily weights, make sure you're eating fruits and vegetables, high fiber. For these guys, we don't want them to do those leafy green vegetables because they're high in vitamin K. So while they might think they're doing the good thing by eating, really healthy green foods, if they're on an anticoagulant, you got to take that down so that they don't just kind of contraindicate. Make sure they understand if you're taking Xarelto, Eliquis, Coumadin, any of those, they can't be just like taking ibuprofen anytime they feel like it, or aspirin, because again, we have the risk of bleeding. Okay. So, practice questions. And I know that everybody did not like select all that apply on the test, but I promise you, there will never be more than 20% as select all that apply. So it seemed like a lot, but I promise I stayed right within what I said I would. But if you have a client who has a pulmonary embolism, what are you going to expect that they have? B, D, and E. So B is a friction rub, right? And what is a friction rub? Where am I going to assess for that? You're going to listen with your stethoscope to the lungs, and you're going to hear kind of like a grating or a rubbing sound. It's very unique to the pulmonary embolism. Hypertension, do we expect to see that? Yeah, we do, because they're gonna end up, hypotension is expected because all the blood is backing up, so it's not getting to the heart, it's not being pumped out. And, tachycardia. So B, D, petechiae, with what particular type of PE? Valvular, right? And tachycardia. So slow breathing is not expected, and high blood pressure is not expected, low blood pressure is. Okay. If you are giving somebody a thrombolytic, which of these would keep you and trigger, this is not a good idea? That's a contraindication. Okay. Yeah, A, you made your surgery within a couple weeks, you don't want to probably give you massive blood thinners. Okay. If you are giving heparin, right, what lab goes with heparin? ACGT. Okay, so you're administering heparin, which of these statements would be concerning? Okay. How many people take B? Why would that be concerning? If you're taking antacids over and over, probably what's happening to your gastric system? Probably some lesions in there, probably some irritation. So if we go ahead and give you a blood thinner, you could cause gastric bleeding. Okay?
So. Yeah, it's
All right, you guys wanna take me out back and tar and feather me. Tomorrow in lab, yes, we are gonna have a quiz. 15 questions. I think there are 2 on triage, the rest are on shock. Okay, so that thing you had to watch the micro lecture. Yeah. Oh, yeah, the math disaster.
Okay.
You want that? Yeah.
Did you say the questions again?
There's 15 questions. 2 of them are on that mass disaster, like start triage system. It's the assignment you had to do with the case study. Okay, there's 2 questions on that, 13 on shock. After that, we are gonna have a 2-part. A patient presents to the ER, that patient is then transferred to the ICU. Tomorrow is gonna be all, one half of lab, all on shock. Reinforcing everything that we're doing on shock, how to treat it, what to look for, all that information. The other half of your lab is gonna be on PE and vasculature. We're gonna do hands-on on how do you treat and what meds do you push and all of that. So you're gonna have almost 4 hours tomorrow, minus however long it takes you to take the quiz, of not any new content, but we're gonna be applying it. Okay, so it's gonna at least hopefully make some connections so that you're not just going home and thinking I have to study all of this with no help whatsoever. So tomorrow, hopefully you'll leave feeling a little bit better about the content. Now, if after today, it is completely clear that we have to move some of this content to another exam, I will. I kind of don't want to, because this is the pace that we have done. And in last semester, even with a little rough start, we lost nobody. Everybody passed the course. Okay, so I feel confident that while it takes a little bit to get used to, you'll do fine. You'll do fine, you'll make it through, okay? But if overwhelmingly everyone's saying like white flag, can't do it, then we'll have to move it, just knowing that we'll have to plug it in somewhere else. Okay. How much do you know about peripheral vascular disease? My clinical group yesterday is like, if I hear one more thing about PVD, like they seem very, I had 23 yesterday. They said this is something that you guys have hit over and over. Maybe they're lying to me, I don't know. Have you ever done aneurysms?
No.
Some yes, some no. Okay. Aneurysms have to go on this exam. Okay, this is the place it fits. It has to go here. When we get to the other venous stasis, that kind of stuff, that I can move and I'm comfortable with that, but it all ties together. Because what happens if an aneurysm bursts? We have hypovolemic shock. What's on the step? Shock, right? It all has to fit together. So, that said. Okay, an aneurysm is a section of an artery that has balloon damage. That's what it is, plain and simple. And we've talked about pressure. We've talked about the vasculature. We've talked about cardiac output. This ties in. That's why it has to stick with this, this topic. The most common places are your aorta, right? And so remember that comes off the top part of the heart. And it goes straight down the center, and that's what feeds your kidneys, it feeds your liver, it feeds all of that. Most of the time that we have an aneurysm, right, it has to do with that arterial sclerosis and atherosclerosis, okay? Arterial sclerosis is the umbrella, atherosclerosis is what we've been talking about. The plaque in the arteries for coronary heart disease, right? That falls underneath that category. Okay, so when they form, they can either form what's called fusiform, or like the whole thing, right? The whole thing balloons out evenly. Or it can do what's called saccular, which is like a little outpouching this way. Okay, so there's two different ways it can, either way, the whole artery can give way and the whole thing can expand, or it can be one weak spot where the pressure of the artery kind of balloons it out, either way. Where we get concerned is when we have a dissection. And that's what happens when, just like when we talked about atherosclerosis, right? You've got a little hole, a little scraping in the vein, and the plaque comes, and the platelet folders on top of that, right? It all happens within that arterial wall. Same thing with this, only instead of plaque going in between that wall, it's bleeding. So it's blood accumulating in between. And so think of it with each squeeze of the heart, every time the ventricle contracts, there's pressure, right? We've got that preload, we've got our afterload, all those terms. With each squeeze, then the pressure of the artery, it starts to split more and more. And instead of the blood going from point A to point B, it goes to point A and it loses a little bit in B. And the next one, it loses a little bit more, and it just starts to accumulate, and that stretching, it reaches a breaking point where that bleeding within there can't take it anymore, and then it ruptures, right? And then we have massive hemorrhaging. So we talked about hypovolemic shock, how if someone is losing blood volume, their hemoglobin and hematocrit are dropping, but you're looking at them and you don't see bleeding anywhere on the outside, this is one of the reasons why it's in the inside, okay? So life-threatening if they have an aortic dissection, okay? So when you look at your structure of your aorta, your arteries, you've got collagen and elastin. And what happens is the collagen then keeps it from being strong and holding in one spot. And the elastin, obviously, it's elastic, allows it to stretch. So when those two things start to get compromised, that's what leads to these pouches, okay? So it can either happen in a true way, meaning you've got high blood pressure, you have atherosclerosis, and over time, slowly, it starts to balloon out, okay? That's your true aneurysm. That's where it's all stretching in one spot. Or you can have an aneurysm that's caused by something. So if you're in a traumatic accident and you have blunt force trauma to your belly or your chest, that can jar the artery enough that it weakens it in one spot, and then you end up with an aneurysm. Okay, so it can be gradually over time, or it can be all of a sudden. Okay, so your thoracic has to do with obviously anything behind your rib cage. Okay, that normally is caused by your atherosclerosis and your high blood pressure because it's protected, right? Unless you have a crush injury to your chest, which hopefully, is pretty rare. It can happen that way, but most of the time it's going to happen over time, right? If it's in this part here where the arch is, right, in the aortic arch, you might not even have symptoms other than like a hoarse voice that you really can't explain, or maybe some trouble swallowing because of where it is, right? It's right at the top part of your heart. Whereas if it's going down this way, toward behind the heart and down, you might have symptoms of heart failure. So again, lots of the same symptoms, we just need to figure out where it's coming from, right? So you're gonna have pain and heart failure, but are you gonna have any elevation in troponin or EKG changes? Probably not. It's coming from something else, right? The most common one you're gonna see though is what we call our AAA. Okay, that's our abdominal aortic aneurysm, and that's where it comes off the heart and it comes straight down, right? So that's our main artery. So all the things that happen when we talked about the heart, all the different ways the heart can be blocked and blood occluded and all of that, it happens through the whole body. So when people have coronary heart disease, I think sometimes we forget all of that that's happening within the heart. It's happening in our carotids, it's happening in our aorta, it's happening in our renal arteries. So it's not unique to one place. When your cholesterol is high, the cholesterol doesn't know to stay just in your coronary arteries. It can also go in your aorta, right? So, same things that tie together, if you are over 65, if you're a smoker, you have high cholesterol. And 90% of it happens right below the kidneys, right? And we think our kidneys are way down here, but they're not, right? They're actually underneath your rib cage. So right between the end of your rib cage, right below the kidneys, and right to the femoral area, right to the top of your leg, that's where a lot of times we see them. This is the most common. So when you are doing your abdominal assessment, you remember back to health assessment, what is the difference in the process when we do that? Remember the IPPA inspection, percuss, palpate, remember all this? Okay, when we have our abdomen, one of the main reasons why they have you look first and listen and do all those things before we touch is because we don't want you to push down if there is a weakening of an artery. If you do a good deep palpation, we pop it. So we listen first. If you hear a swooshing sound, right in the middle, that we call that a bruit, and that is the blood, instead of just pumping from point A to point B, as it's churning in the aneurysm, you actually hear it kind of whooshing. So anytime you look at a belly and you see something kind of pulsing, or you listen, we're supposed to listen to all the quadrants of the belly, right? If you hear a swooshing sound, definitely make sure you're not pressing on it, because that aneurysm could burst, right? And if it bursts, obviously that's our main highway of blood to everything. We're gonna end up with hemorrhagic and hypovolemic. We can get them in our legs too. A lot of times with that though, it has more to do with arterial sclerosis. So it's a long way from your heart down. And so they can form down in your femoral artery or down behind your knee. But remember, like the perfusion, like the pressure is less as you go down. It's further away from the heart. So they're not as common. One of the main things that we see though is called intermittent claudication. And that's where as you're walking, as you're moving, you're starting to get like ischemia happen and you get a lot of pain. So as soon as you stop, it goes away. So it's sort of the same idea of angina, right? Blood's not getting to the muscle, you're moving, it hurts, we rest, it feels better. So that's kind of the leg version of angina, okay? Again, anything that we find that is pulsing, we don't push on it, right? That makes pretty good sense, but we do want to listen because there can be groovies there as well. So when we're talking about the dissections, which are life-threatening, this can be slow, meaning you've got hours. It can be fast, meaning you have minutes. All right. And I've seen patients that have come in and a lot of times what they're complaining of is back pain, or this horrible like ripping pain. And we send them to CAT scan and they come back and they are purple from here up and they are pale from here down. Because everything has blood up this way, there's no blood going down, so it happens very, very quickly. So anywhere along the vessel, it can happen, but like I said, it can go very quick. A lot of what they will describe is ripping, tearing, stabbing, and we're not talking like, oh, I'm a little uncomfortable. A lot of times they're saying it's in their back, or in their chest, or in their belly, depending on where it is, and they will be unconsolable. And they have a look of terror on them, and you can just tell, like spidey sense tingling. If they have a history of Marfan syndrome, this is very common. Marfan syndrome are the real tall, skinny people. They've got sometimes a concave chest. Part of the genetic abnormality with Marfan, it has to do with the lining of the aorta, and that's very common for them. But I wish I could have like a picture of somebody that was going through it. Once you see it one time, you will not forget it. But chest, back, belly, ripping, stabbing, unconsolable, very confused, very scared. That's where we're gonna lead to, okay? And what happens is they very rapidly go into hypovolemic shock. And obviously, if you're bleeding out, anything below where you're bleeding out, you're not gonna have pulses. So if it's up here or in the belly, they're not gonna have pulses in their feet. And, if they cannot get to surgery pretty immediately, it's not a very good outcome at all. Okay, so let me show you a quick video here on that. Has anyone had a family member end up with aortic dissection?
I died from one.
Did he have symptoms beforehand?
Well, he was a smoker and a truck driver. So. I don't think he
We
actually
had,
has
I don't know if any of you remember, John Ritter, he was the guy on Reed Company. He was on a show, Rules for Dating My Daughter or something. Anyway, he was complaining of back pain during the day. And he was trying to finish shooting and he said, I'll go to the doctor afterwards. And he's having back pain, progressive nausea, vomiting. He started feeling lightheaded. And by the time he collapsed, they got to the hospital, he had completely dissected. So he had a thoracic aneurysm. So all of his symptoms were up in here, into the back, and it was within minutes that they were, I mean. And think about it, if you have somebody who is asystole or needs CPR, every time you pump on their chest, it's not delivering the blood where it needs to go. So it's something that can be really catastrophic.
That's kind of a very nice story. My grandmother-in-law, her husband committed suicide, he hung himself. She was lifting him off and created an aneurysm that she died from eventually. But they think that it was the weight of lifting him down that caused a
Overstretch that artery.
Yeah, because she had already had heart disease and all that, so. Even the weight. from that
It's
test.
just bizarre because you think about, again, we talk about stroke valve, we talk about cardiac output, your ejection fraction. So if your heart ejection fraction, 55% of your blood with each pump, every time you pump it, it's ripping. I mean, people will be sitting up fine, go to CAT scan where they're looking for it, and by the time they lay them flat, it's already ripped. And it's the most bizarre thing. It happens so fast.
The aorta is the largest artery in your body. Your heart pumps fresh, oxygen-rich blood through your aorta to deliver oxygen and nutrients to all your organs and tissues. Your aorta is divided into two main sections, the thoracic aorta and the abdominal aorta. The thoracic aorta has four parts: the aortic root, ascending aorta, aortic arch, and descending aorta. The wall of your aorta is composed of three layers that give it strength: the intima, or inner layer, the media, or middle layer, and the adventitia, or outer layer. The elastic muscular media prevents your blood pressure from rupturing the wall. Over time, degenerative disease may cause the media layer to break down, weakening the wall of your aorta. Blood pumping against the weakened area may cause it to bulge outward like a balloon. When this condition occurs in your chest, it is called a thoracic aortic aneurysm. These aneurysms may occur in one of several places, including the aortic root, the ascending aorta, or the descending aorta. Most thoracic aneurysms have no symptoms. However, when they reach larger sizes, various symptoms may appear, depending on the severity and location of the aneurysm. Symptoms of stable thoracic aneurysms may include shortness of breath, chest, back, or abdominal pain, difficulty swallowing, and hoarseness. If the aneurysm ruptures or dissects, more dramatic symptoms will appear, including a ripping sensation in the chest, severe pain in the back between the shoulder blades, dizziness, and difficulty walking and speaking. If you have these symptoms, you should seek immediate medical attention, as this condition is life-threatening. Blood pumping against weakened aortic walls can lead to another life-threatening condition called aortic dissection, which may or may not occur within an aneurysm. Most commonly, aortic dissection begins with damage to the intima layer. Blood moves through the break in the intima, separating it from the media, causing bleeding inside the wall of your aorta. As a result, a flap called a septum forms between the true aortic channel and the false channel. From here, the blood may break through the outer layer of the aortic wall, causing an immediate life-threatening condition. Or it may re-enter the aorta through another tear in the intima. Over time, a blood clot may form in the false channel. An aortic dissection may be classified according to its location and duration of symptoms. In the Stanford system, if you have an aortic dissection in your ascending aorta, it is called a type A dissection. All other dissections are called type B. The most common symptom of thoracic aortic dissection is sharp or stabbing chest pain, usually sudden and severe. If you have a type A dissection, you're most likely to feel pain in your chest. If you have a type B dissection, you're more likely to feel pain in your back than your chest. If you have these symptoms, you should seek immediate medical attention, as this condition can be life-threatening.
Back in 2022, I lost two very important people in my life, big figures. It really,
Okay, so looking at that, you see the correlation of the similarities between atherosclerosis in the heart and arteriosclerosis in the aorta. You can see how they can all go together. Okay. So looking on CAT scan, you can see where, looking at above and below, and then you can see the dissection. So the top part there, you can see in the middle where it is ballooned out. And then on the bottom there, you can see where the bleeding has expanded within the abdominal area. Okay. In your book, don't expect you to memorize this, but in your book, it will actually spell out a little bit on different symptoms. So what we talked about, it kind of goes in a little bit deeper, just to give you, so if you're wondering, like, what's the difference between chest pain and what's the difference between shortness of breath? Take a look at this table and it'll explain the different types. The things we use to check for this, we can use a chest x-ray. A lot of times you can see them on an x-ray. You can do ultrasound. You can do that TEE again, where it looks at the backside of the heart and you can see if there, you can look at the ascending and the arch. You do a CAT scan, or again, that angiography, which is like the CT scan that we use for the CAT lab that we do for the heart, and we can do it for the lungs for PE. We can also use it for here for the aneurysm. Same type of medications. So what is our goal with the beta blockers? We want to keep the heart rate low, just like we want to keep it low to confuse the heart. We want to keep it low so that we're not overstretching, increasing our afterload, right? We want everything to slow down. Our priority for our blood pressure then is we want to keep the systolic between 100 and 120. So very important that we don't drop it too low, because we still need to perfuse, but we don't want it above 120. Okay, so we use beta blockers. These should look pretty familiar. And we also use some other antihypertensives. We'll get to those in a hot second. Then afterwards, right, we're probably going to put them on an anticoagulant because we've got that injury to the aorta, and we want to make sure that we're not trapping anything that's going to cause a blood clot. So if we know it's there, we can watch it. So we don't even, if it's not bleeding, it's not dissecting, we can just keep an eye on it, and they'll do every 6 months or every year, they'll take a look. As long as the abdominal one stays below 5, they'll just consider it stable. If it's less than 6 in the chest, they consider it stable. So they'll just keep an eye on it. If it suddenly gets bigger, or starts to rupture or dissect, then we have to do surgery right away. And yes,
Why would we not do surgery sooner? Because if we know it's eventually gonna rupture,
because of the risk of the surgery.
okay,
So it will depend on, just like in the heart. We probably wouldn't do anything with the vessel until it reached 50% blockage, because the risk and the benefit, you have to make sure that they outweigh. If it's a stable aneurysm, if it's a 3 centimeter, it may stay that way for 10 years, right? So to do the invasive surgery. So again, just like in the heart, we can try a stent. We can try to stent it to hold it back together. Or if it ends up being something really, really dramatic, and we can't fix it with just a minor procedure, we can do the open. Same thing as the heart. We'd love to go in and stent it, but if the disease is to progress, we have to do open heart. Okay, so it's the same type of thing. You can look at this video, it actually explains the difference. So the endovascular repair is very similar to what we would see in a cardiac cath lab, where you would go in, you would deploy what needs to be there, you're gonna reinforce it, and then that will stabilize the aneurysm and provide structure. Same type of procedure, right? The open one, again, it is an open surgery. I tried to find a picture of an open surgery, but they were all too gruesome, so I just you can look them up on your own. But just like for open heart surgery, they take the saphenous vein, right, and they bypass and reconnect. They use a synthetic fabric graft to either wrap around or to bypass that area. So it's very complex, right? Open heart surgery, if it's in the thoracic area, it's very, very extensive, and that's why they want to hold off unless it really is becoming unstable. You have to go on bypass. It's the same type of thing to reperfuse your heart. Okay. This is what they have to go in and do then. They use that different grafting material. Sometimes they can do a small area and excise it. Other times they have to reconnect a whole lot. Right, so again, very invasive. We want to monitor it if we can. Once we get that graft in place, then we have to watch, because it has to still provide all that circulation to your legs, to the periphery, and we have to really, really watch to make sure it's not leaking. So watch it if it's leaking before we fix it, and then watch it if it's leaking after we fix it. So we're gonna watch for any type of bruising, right? Anywhere from the chest, the scrotum, the perineum, any type of increase in abdominal girth, right? So we want to look and see if the blood's collecting this way. Check pulses, that would make sense, right? Anything below the surgery site. Make sure that not only do they have pulses, but do they have any numbness and tingling? Like, are they getting enough blood flow? Gotta look at that hemoglobin and hematocrit, just like in shock. We have to look at it. If we don't see external bleeding and it's dropping, we have to figure out where it's coming from. Anything that was hurting that comes back. So if the pain was resolved from the dissection or the rupture, and then 2 days after surgery, all of a sudden those symptoms are back, that would be a big indicator. Make sure those kidneys are perfused. In shock, we know the blood diverts to the heart and lungs and brain. Same thing here. Make sure those kidneys get what they need. And then all of those advanced hemodynamics we talked about, the arterial line, the central venous pressure, the wedge pressure from the pulmonary artery, all those things we have to look at. Okay. Very similar for this, as opposed to when we did the coronary artery bypass graft in the chest, same type of thing. We're gonna watch all of this. We're gonna look at the perfusion and the assessment. Here's a big difference though. We don't want them bending because we've got that new graft and we don't want to flex it for quite some time afterwards. So a lot of the same things. This one's different though. With our heart patients, we got them up and we got them in the chair within 24 hours. With these patients, we don't want them bent more than like 45 degrees. Okay, until that graft has a chance to really take hold. And the things, again, these are very similar. Make sure that we're using our blood expanders or our fluid, right? What are our crystalloid fluids? Normal saline, lactated breakers, right? So we wanna make sure we expand the fluid volume, or we can use our blood products. Okay, we wanna make sure we're assessing anything below that site. We've gotta make sure we're checking the feet, we're checking for pulses. Because it does feed the bowel, we wanna make sure we're checking for any type of GI bleed, urine output. And then we have to make sure that they understand, just like the heart patients, we gotta change the diet, gotta watch the blood pressure, get your blood sugar under control, quit smoking. All of that teaching that we've been doing over and over. Okay. If you have a client who has a dissecting abdominal aortic aneurysm, what is our priority? So think about the mechanics, right? What are they at risk for developing? Hypovolemic shock. We already know what we do in shock. Okay, so that's where my mind would go with this question. So what's our answer gonna be? C, we're gonna do fluids. Now, warm environment. We wanna keep these patients warm, why?
To keep vasodilation.
We want them dilated because we have a limited point A to point B, there's an interruption. We wanna get all that fluid, get all that blood to the periphery. So if they're cold, what happens? The vasoconstrict, so we wanna keep them warm. That's something we do wanna make sure that we do with them. Make sure our vessels are dilated, but that's not our first priority, right? The first priority is making sure we do the volume. Okay, what if we have the graft that they just had put in? What would make us think it's occluded? Good, what's the answer? C, right? If they're bleeding in the middle, then we would expect it to be distended, right? We expect the urine output's gonna go down, pulses are gonna go down, they're gonna be pale below the site, so that's what we're gonna take a look at. Okay, we're not gonna take a break just yet, because I want to go over like 5 slides that have to do with blood pressure medications. And then I think we're gonna not do the last part. I think I'll move it to a different next. And we'll do a review. Does that work? Okay, so. One of the things that can aggravate an aneurysm is a hypertensive crisis. Okay, so that is something that rapidly elevates your systolic and diastolic. Greater than 180, greater than 120. Okay, if you have someone whose blood pressure spikes that high, you have 1 hour to get their blood pressure down. And a lot of times it's what happens when they stop taking their medication, right? Or maybe they have a pheochromocytoma, we'll talk about that later, but something causes it to elevate. Here's the thing. Our first instinct is to bring it down. We cannot bring it down too fast or what will happen? What will happen? They will stroke. They will stroke out and they will lose their cardiac output and we have a whole nother problem on our hands. So if you have somebody that has massive elevated high blood pressure, right? So they come in with an aortic aneurysm that is starting to leak and their blood pressure is sky high. We are gonna drop it no more than 25% at first. We want to address it, but we're not tanking it. And then over the next couple hours, we're gonna try to bring it down to about 160 over 100, low and slow. Okay, is what we wanna do, to slowly bring it down. In your book, there's a list of medications that we use for this. So if you have somebody who's experiencing hypertensive crisis that's interfering with circulation, here are the ones that I want you to pay attention to. Okay, these are the emergency meds that you will probably hear. Sodium nitroprusside and hydralazine. Has anybody ever heard these before? Okay, I'm comparing the two. Nitrite is what you'll probably hear it called as. It works in seconds and it lasts very short amount. So this is one you're gonna titrate a lot, means you're gonna give it It wears off very quickly, but you can crank it up. The problem with it is it works so fast and so powerful, sometimes it can mess with your intracranial pressure. So that's why we have to be very careful with it, but it's super effective. Might cause nausea, vomiting, could cause some muscle twitches and sweating. Okay, but it works very quickly, very easy to titrate, very rapid. Whereas hydralazine, this is one you might have to push IV, sometimes they give it in a pill. This one takes about 10 to 30 minutes, but it lasts 2 to 6 hours. So this is one where it takes a little bit longer to kick in, but it does last longer. It's gonna have the things you would expect, right? The heart rate's gonna go up, we might have some chest discomfort or flushing because we're dropping the blood pressure. But we don't wanna do it if we know they have coronary heart disease. So if we know they have a history of this, we're gonna use another medication first. Okay? And here's one that we've already talked about when we talked about angina. We talked about nitroglycerin, how it's a vasodilator, it increases your oxygen capacity. This is if we're gonna do it in a drip or an IV form. So it can work as quick as 2 to 5 minutes, not real long lasting, and we're gonna make sure we titrate this, okay? The problem with nitro is they already take nitro at home. They already take like Imdur or something that's long acting. They can build a tolerance to it. So you have to kind of play with it to get where they need to be. Okay, this is a really good one to use when their blood pressure is high. And it's also causing some cardiac stuff, right? We know this, we talked about this, if they have an acute MI, that nitro is one of the things that we're gonna do. Because it's gonna help to drop the blood pressure by vasodilate, same thing. We talked about with this one, it can cause a headache. So if the one under the tongue causes a headache, the IV also will do the same thing. So again, education when you use this one. We've talked about these two classes, our ACE inhibitor and our calcium channel blocker. We talked about amlodipine and we talked about lisinopril, right? These are just the IV forms that we can use for these. So the cardine, the nicardipine, okay? Rapid onset, 5 to 10 minutes, lasts about a half hour. Sometimes in some people it lasts a little bit longer. This we're not going to use with anybody with heart failure. So you have to know what's in your toolkit based on what your patient's history is. Another one is enalaprilate or Vasotec is what I always hear it as. Okay, this one lasts a long time. This one used really, really good in left heart failure. Okay, to help work on that particular area. We don't want to use it in a heart attack. And our beta blocker. Here's the difference between labetalol and your other beta blockers, your metoprolols, your propranolols, okay? Labetalol does all the same things that our normal beta blockers do, except it also works on blood vessels. So we give it, we want our heart rate low, we talked about this, when to hold it, but this one actually will work on blood vessels also. Okay, and we're gonna use it with caution, just like we do the beta blockers with the asthma, with the heart block, all the same things that you have learned already about beta blockers. Just understand labetalol works faster. The IV form works in 5 to 10 minutes, lasts 3 to 6 hours, and it works on the heart and the vessels. Okay. Are we good with that amount of material? Yes. Okay. Why don't you take a quick break and I'll see what I have for review materials on this topic and see if we can take the last 50 minutes to do some studying together instead of adding in here. Okay. All right, so these are 5 questions on pulmonary embolism. We'll see how you do. Think about what we talked about. How it's a clot usually, where does it start? Where does it travel? How it goes from bigger to smaller. Next one. You're good. All right. We'll take this together and we'll submit it and see how we do. So which one of these explains the pathway? Where does it normally start? The deep vein, then it goes to where? The right heart, then pulmonary artery, and then where? Okay, so you feel pretty confident that that's the right answer? I haven't taken this yet, so I hope that's right. Okay. What is a sign of them going into respiratory failure? Heart rate, cough, respiratory rate, or cyanosis? Cyanosis. Cyanosis. Do the other three indicate respiratory failure? Not really, not necessarily. What lab test would I want to do if I saw this? An ABG, probably, yeah. All right, select all that apply. We know we love these. Can air cause a pulmonary embolism? Yes. What about blood clot? Yes. What about fat? Yes. What about plasma? No. No. What about tumor? Yes. You feel confident on that one? What labs do we want to do before our first dose of heparin? What one jumps out at you? APPT. What about the other ones? We want to look at a base excess. That have anything to do with their ABPs? Probably not. What about platelets? I want to know those. Hemoglobin and hematocrit? Yeah. I honestly, I don't know if I would have chosen those, but we'll find out if I'm right or wrong. Anybody think, have a real strong argument for why you want to do hemoglobin hematocrit? You think you would? You were allowed to believe? Okay, that's a good point. Maybe, we'll see if we're right. And for this one, what data particularly stood out to you when you were trying to make a decision? Closing your chest. Does the EKG matter? Or the IV or the oxygen? Kind of there to kind of confuse you. Normal sinus rhythm, but they're anxious, sweating, clutching chest. Is that important? Yeah, that one is important. Okay, now we're looking at a more assessment. Redness and swelling of the leg. What does that indicate to you? DVT, okay? So let's look at non-STEMI, okay? Chest, so we have the normal EKG, stroke. Does that really have anything to do with stroke or hemorrhage? Maybe not. So I would say VE. Let's see how we did. I haven't taken this one yet, so I think no. Oh, we missed one. We were right on the deep vein to the right heart, the pulmonary artery, the arterioles. We good on that? We are correct. The cyanosis would show the heart failure. See if Kristen's right here. Okay, this one's right. All of those are correct, right? Air, blood clot, fat, tumor, all cause PE. Here we go. It did say that. Now let's see why. Any drop in hemoglobin and hematocrit would lead to suspect hemorrhage. Hey, Kristen was right. Same with hemoglobin. Since it's an anticoagulant, leads to an increased risk for bleeding. So hey, I would need to include those. And yeah, we were right. EKG was normal, but the sweating, the chest pain, and the signs of DVT let us know it's a PE. Right? When you do your Kaplan, when you do your remediation, do you read them like that? Go back through and see what they all look like? Is that helpful? Yeah. Okay. Let's try another one. Who's in here? Okay, so that one is staying. Let's see. Okay, let's look at question 2. What is afterload?
The pressure that it has to fight to get out.
The pressure that is pumping against, right? Back to that first question, see if we know the answer again. What are our causes? Fat, yes. Air. blood clots, tumor, okay. Next one. So right ventricular afterload. Okay, so if that's gonna impact our heart being able to beat and pump effectively, right, with that blockage. So what is our priority concern? What of those has to do with how the heart's pumping? Cardiogenic shock? Are we at risk of a heart attack? Or decreased urine output or stroke? Anybody have any strong feelings other than cardiogenic shock? They have a strong feeling that like MI is the way to go? Or the kidney? No? Okay.
In cardiogenic shock, MI is, you know, it's like one of the most common reasons for cardiogenic shock, so wouldn't they go hand in hand?
Other
like-
things can cause cardiogenic shock other than MI. Okay, so in that question, it's saying we already have a cause, right? If it said a client with MI, cardiogenic shock makes sense, but there's other things that affect the pumping ability of the heart as well. Okay? What order did you want to do first?
ETI.
Labs? Anybody not want to do labs first? Because all these are right, but it's a prioritization, right? A, B, C, D, whatever. Okay, and what's the right one for this? Where do we start with? The vein? To the heart? To the artery, to the arterioles, okay? Okay, and again, what values do we want? We got this one wrong last time, we're not making that same mistake. Okay, and then what lab is the highest priority before we can start our heparin? Regulations. You know, we did. Are you gonna forget? Oh, look at that, you got it fine. Does that help? I know that there was a lot of information on the pulmonary embolism, but these are the things I want you to know, like the basics. I'm not trying to trip you up, want you to know it's life threatening, I want you to know what you have to do when your patient comes in with it. I want you to know your assessment data. Care plan, right? Don't get lost in the details. Then the other thing I have is a septic shock case study that we can do together. I was like scrambling, guys, sorry. Okay, so can you read this or not really?
No.
Yeah? All right, out of this. If we were to highlight the parts that were really important. What are the things that you would consider really important that we need to know? Confusion, anxious. Urine output. What else would you want to highlight? Pain. How about these diagnoses up here? Are they important? Okay. Okay, so we kind of have an idea. So. Highlight the assessment findings that should be reported. So we have our nurses note, we already have an idea. So based on these results, which of those are concerning to you? Oxygen. Blood pressure. Temperature, right. Okay, so we're gonna go back through here. So you correctly picked confused and anxious and short of breath. Yeah, well, that's great. We talked about pain. Talked about our intake and output, because we have a big mismatch, right? Definitely want to be concerned about that oxygen. Definitely concerned about the blood pressure. And the fever. And I think the respiratory rate, what's the normal respiratory rate for an adult? Okay, so we're elevated. Okay, so on your NCLEX, I'm not able to give you a question like this, but on your NCLEX, this is the kind of thing you're gonna see. They're gonna give you a scenario and ask you to pick out what's important. Okay, so if a test question said, you have a patient admitted with osteomyelitis complaining of feeling anxious and short of breath. Right? And I said, which of these vital signs would be most concerning? Select all that apply. Would you be able to answer that? Yeah, makes sense. Okay, now we're gonna look at their labs. Select the 3 that you would associate with sepsis. It even gives you the normal values on the side of that. Does it?
No.
No, oh, I thought it did. I was just giving a different value there. Okay, sodium, high or low? What's a normal sodium? Okay, so is this, how high elevated is that? Yeah, pretty, okay. Potassium, what's a normal potassium? 3.5 to 5, is that normal? Okay, normal creatinine. Below what number? 1, is this elevated? Yes. What about its serum glucose? What should it be under? 100, is this elevated? Yeah. White count, 3.8. Is that high or low? It's low, 4 to what? 4 to 11 is normal? And platelets of 105. Right, is that high or low? Low. So which of these labs do you think go with sepsis? How many people say platelets? We gotta pick 3. You want platelets? Yeah. Okay, what about, oh, it picked creatinine for me, never mind. If creatinine is high, why does that make me think sepsis? Perfusion on the kidneys, right? What's the next one it wants us to pick? White count. Remember we talked about sepsis and how a high white count can be indicative of sepsis and a SIRS alert, head towards septic shock, but also a low as well. What's the last one you think is gonna highlight? Platelets, yes. Why would platelets be a problem? Bleeding, hypovolemia? Okay. The nurse anticipates the top priorities are gonna be to do what? What's our first goal of shock? Improve tissue perfusion. If you see a test question that says, what is the goal of shock? The goal is to improve tissue perfusion. Okay? And what is our other top priority? Prevent further infection. What is our patient here for? Now, is decreasing anxiety or education, feelings and education, ABCs, airway, breathing, circulation, safety, D, discomfort, E, education, F, feelings. So are education and feelings important? Yes. Right now, are they most important? No. Go with the safety thing, right? Yeah, prevent further infection. Make sense? Okay. All right, now, what are we gonna do and what are we not gonna do? So looking at those, indicated, yes, we're gonna do it, contraindicated, no, we're not. Remember, why are they here? What about the first one? Are we gonna encourage them to ambulate? Why would we or would we not? Because what were their vitals on the first page? Not good, and they're here for what? Something with their foot, so we probably don't want them up and moving. They're infectious, they have low blood pressure, their SAT's low, we don't wanna get them to get up. What about doing a neurostatus? Yes, what's often the first sign of shock? Altered mental status, yes. What about monitoring the stools for blood? Yes, is that important? Is that hurt you think? Yeah, we do, because what happens if they are already septic? What are some of the things that we are concerned about? Is that the gastrointestinal bleeding, right? And what were their platelets? Low, so even if they did have some bleeding, they're not gonna clot real well, right? What about IV fluids? Remember what their blood pressure was and their fever and everything. Do we wanna do fluids? Okay. What word do I not like in this one? All. I don't like that word. Are we gonna keep all the visitors away? No, we can maybe keep some, might have some limitations, but not all. Right, make sense? Okay. So this is a question that you're gonna start seeing more and more. We're gonna slowly work these in. What can you delegate? One of the things in the scope of the registered nurse is you are delegating to LPNs and they call them unlicensed assisted personnel. That's your PSA, your PCA, or UA. Which of these can you give to them so that you can focus on your priorities? Okay, what about measuring, recording files?
Yes.
Can I do that? Okay. Right, what about changing a dressing and getting a culture? No, we can't have them do that. Oh, well, we can have them do a glucose. Right, what else can we have them do? Okay. We can do hourly output and we can do a bed change. So they can't draw from a big line and change a dressing. That's sterile. Can an unlicensed person give oral medications? It doesn't say with extensive training, right? Because there are some certifications, doesn't say that. It doesn't say, are we gonna, do they do any assessment whatsoever? No. What about irrigating a catheter? That's invasive, right? So those are the 4 things that I can offload off of my to-do list so that I can do my priorities. Okay,
So UAP, you said that LPN falls under that, but it
No.
doesn't.
it doesn't,
Doesn't.
it does not. What you can delegate to an LPN, in that scenario, it was an unlicensed person. So LPNs are licensed, obviously,
Right.
right? Yeah. Okay, so which findings indicate that we have been effective? And which do we have to tell the doctor about? So what if they are lethargic and confused? We go to bed, doctor. What if their pain is gone after we give them pain medication? Okay. What about the foot now smells real bad? Okay, what if their blood sugar is 112? Okay, because what was it? Okay. What if they're, we put them on our oxygen and their sat goes up to 98 and their respiration's dropped to 20? And then what if our urine output is 20 mLs? What do we want, what does it have to be for 30, then we know that the kidneys are perfusing, right? Does that help how we kind of put it together? Okay,